This is my second video on blood coagulation. We'll focus on control in this one. The learning objectives will be you should be able to explain the anticoagulant functions of aspirin and Plavix, describe the role of vitamin K and how warfarin inhibits vitamin K function, explain how INR values, INR stands for International Normalized Ratio of Prothrombin Clotting Times, values are used to manage warfarin dosages, describe the role of genetics and warfarin metabolism, tell where heparin comes from and how it works as an anticoagulant. Aspirin and platelets. Aspirin is a civicide inhibitor of platelet cyclooxygenase 1 that produces thromboxane, which causes vasoconstriction and activates more platelets. So once you get a cut, you would like to have active platelets working, because they will form a plug at the place where you cut your finger, and then they'll activate more platelets to function. Aspirin irreversibly inactivates COX-1 and COX-2. Remember, COX-2 is needed to maintain your intestinal mucosa, and so that's one of the reasons aspirin's hard on the stomach. But platelets only have COX-1. Consequently, taking aspirin slows clotting. And a number of people, older people, tend to take 81 milligrams of aspirin, but they should only do that under certain conditions, as you will probably find out here. Plavix, or clopidogrel, is a drug used to slow clotting in patients with coronary artery disease by preventing platelet aggregation. It prevents ADP, adenosine diphosphate, from binding to a receptor in platelet membranes, which is important in platelet aggregation. So if ADP doesn't bind, they don't aggregate well. So if we can prevent that binding, we can bind something else to that binding receptor, then the ADP can't bind. So here is a blood clot. We've looked at this one once before, Platelet Plug. And here's the endothelium, the collagen underneath that, and then the smooth muscle cells even below that and around the blood vessel. And so here's the platelet, and here's COX-1 that makes thromboxane and aspirin. So aspirin inhibits the activation of platelets by thromboxane, and ADP also activates platelets, and Plavix inhibits that process. Then we have other components. Remember the endothelial cells, and then von Willebrand factor, which is made by the endothelial cells, links the platelets, the activated platelets, to the collagen underneath there. And then fibrinogen cross-links the platelets in place, and finally you have a nice blood clot. The next component we're going to look at is the gamma-carboxyglutamic acid, or GLA, and vitamin K. Now here is various precursors of the blood coagulation proteins that are made by the liver, factors 2, 7, 9, and 10. And they have carboxyl groups on them because they have glutamic acid residues, and the side chains have carboxyl groups. Vitamin K uses CO2 and an enzyme to carboxylate those and put another one on it. This is called a gamma carboxylation. And so you can see over here how that gamma carboxylation, this is the gamma carbon here, and we add another carboxyl groups to it, and so now we have a GLA residue. So we still have the glutamic acid residue with its original carboxyl group, but now we've added a new one, and that's called gamma carbamyl residue, or a GLA residue. And that requires vitamin K, and warfarin inhibits this process. Now, with the extra carboxyl groups on these proteins, in the mature form that comes into the blood, remember this all occurs in the liver, once it gets out in the blood, then these carboxyl groups can bind calcium, these double carboxyl groups. And then once they bind calcium, that helps them to bind to the membrane phospholipids of platelets, and so aggregates them at the site of clotting. The discovery of vitamin K occurred in Scandinavia where cows were fed spoiled sweet clover, and they tend to have a hemorrhagic disease. And so they were looking to see what is involved in that. And this sweet clover made this product called dicumarol. And later, the researchers at the University of Wisconsin developed this compound called Coumadin or Warfarin. They called it Warfarin. Warfarin stands for Wisconsin Alumni Research Foundation, Warfarin. Cows, they started working on this because farmers in Wisconsin were having the same problem, and their cows were dying from dehorning. Now, vitamin K doesn't inhibit the enzyme that converts glutamate to gamma carboxyglutamate. What it does is inhibits the recycling of vitamin K. Vitamin K must be in its reduced form, pictured down here, to use CO2 and O2 to put that extra carboxyl group on. And then once that happens, we have vitamin K in the oxidized form. And then it has to be reduced. There is a vitamin K reductase that converts vitamin K back into its reduced form to be used again. And warfarin inhibits the reductase that does this process. So all these factors have to have gamma carboxyl groups on them and some others. So it's a very important post-translational modification process that adds extra functionality to be able to bind calcium by those gamma carboxyl groups. The international normalized ratio is dependent on the prothrombin test. I told you about that measures the extrinsic pathway. And so here's the normal prothrombin time. And so this is done, and if you have a low INR, you run a risk of having a clot formation. If you have a really high INR, you run the risk of having bleeding or hemorrhagic strokes and things. So you want to maintain in here. So the target INR for people on warfarin is about 2 to 3, and normal people are around 0.9 to 1.3, somewhere in that ballpark. Warfarin pharmacogenomics. Cytochrome P450 genetic polymorphisms. Warfarin metabolism is metabolized by the cytochromes P450s of the liver, so we need a functional liver again. Warfarin is a racemic mixture of R and S enantiomers. The S-warfarin is about 60 to 70% of the anticoagulation response. The R-warfarin form is 30 or 40%. So F-warfarin and R-warfarin are metabolized by different P450s at different rates. Genetic variations in P450s. You can have a very slow P450, half the normal Vmax or half the normal KCAT, and we can have a slow P450 at 10 times the normal Km, for example. So numerous P450 variations, about 26 known at present, and there are even programs that will, knowing your genetic makeup, can decide what warfarin level you should start at. So here's a graph showing what happens if you're a normal individual and the normal dose works really well for you. However, if you're a fast metabolizer, the normal dose is not enough, so you need more. If you're a slow metabolizer, or very slow metabolizer, you can have a toxic dose and start bleeding because you've knocked out your clotting cascade too much. So one of the little things to think about as a nutrition point here, leafy greens such as spinach, cabbage, parsley, and avocado are rich in vitamin K. But remember that vitamin K is a fat-soluble vitamin, so using an oily salad dressing can increase vitamin K uptake by 10-fold, and this can interfere with the warfarin therapy. Diet is important when on warfarin. Additionally, intestinal E. coli make vitamin K, so nutrition and changes in the intestinal flora can affect vitamin K levels needed for clotting. If a patient has a bleeding issue or a high INR, vitamin K can be given to lower their INR, but this can take several up to 24 hours because new clotting factors have to be made by the liver. Antithrombin III is activated by heparin. Heparin comes from mast cells, and this is a picture of a mast cell. Normally it's isolated from pig mast cells, but our mast cells have heparin as well, but it doesn't act as an anticoagulant in our bodies because it's bound up to other proteins in it. But heparin activates antithrombin III, which is a blood plasma serpin, and so once it but it normally binds to heparin in the body. This is exogenous heparin that's added by IV. It normally binds to heparin to slow clotting, but you can speed the process up in patients by adding this heparin, which is highly negatively charged, and we get it from pig intestines. So here is here's the serpin, antithrombin III, and when heparin binds, it opens up this loop and it functions. And then as serpins, as you know from serpin function on alpha-1 antitrypsin, the serpin binds and cuts. Then there's a major conformational change that inactivates the protease. Okay, so that's the end of that. All right.